Bueno, buenas tardes a todos. Un gusto estar una vez más acá con todos ustedes en esta nueva edición de Entrevistas en Cuarentena, la cuarta edición ya. Es un gusto para mí saludar a los coanfitriones, que son la doctora Silvia Quadrelli, neumonóloga del Hospital Británico y jefa de neumonología del Sanatorio Güemes, el doctor Adrián Gasser, que es médico radiólogo especialista en tórax de diagnóstico médico de Buenos Aires, la doctora Beatriz Gil, neumonóloga de Tucumán, de Concepción, y actual coordinadora de la sección de esterticio de la Asociación Argentina de Medicina Respiratoria, y la doctora María Otaola, neumonóloga del Instituto IREP de Buenos Aires. Es, como les decía, un gusto para nosotros presentar a la doctora Sara Tomassetti, que es una de las máximas referencias de Italia y de Europa en neumonología, específicamente en enfermedad intersticial, en fibrosis pulmonares, y ella además es una experta en las criobiopsias por broncoscopía de pulmón. Así que bueno, vamos a iniciar la entrevista, que va a durar 1 hora. Buonasera, Sara. ¿Cómo estás?
Buonasera. Thank you very much for inviting me. So it's really an honor and a pleasure to be here and share some experience about this COVID period and pandemic. Thank you.
And thank you very much for staying awake until now. I know you are a very busy person, and it is 10 now in Italy. Le estoy agradeciendo por haberse quedado despierta hasta esta hora, son más de las 10 de la noche de un sábado en Italia. Así que bueno, vamos a empezar. La doctora Otaola va a hacer la traducción experta como siempre. Sara, Maria is going to translate everything we are talking. Is this okay?
Yeah. Sure. Thank you, Maria.
No, that's fine. I cannot translate even a buonasera in Italian, so I would go with English. If you go with English, I'm okay. If not, Betty is the one.
Ok. La primera pregunta que le vamos a hacer a la doctora Tomassetti es sobre la situación actual de la pandemia de COVID-19 en Italia. Sabemos el gran impacto que tuvo la pandemia en Italia, sobre todo en el norte de Italia. Y ellos ahora han implementado una serie de medidas de relajamiento de la cuarentena, entonces queremos saber sobre cómo está ahora el tema y la cantidad de casos nuevos. Y además, en relación con esto, si hay estudios de anticuerpos para saber qué porcentaje de la población estuvo en contacto con el virus, por ahí algunos inclusive asintomáticos. So, Sarah, let's start. The first question is about the current situation of COVID-19 in Italy, and about the quarantine relax and the number of new cases, and what about the studies ongoing now to test antibodies in the general population to know the prevalence, the real prevalence of the disease. Yeah. So please.
To describe what the pandemic peak has been and what is the second phase that just started and that is much more relaxed, I've prepared a few slides to show you. So may I just share the screen and show you a few slides about our situation?
Yes, you can share the screen now if you want.
Okay. Can you able?
Yeah. Sorry.
That's fine. Not yet.
Just a minute.
Yeah. So basically, okay. So basically, it started. Can you see my the desktop?
Yes.
Yes.
So it started at the end of February and early March, and as you can see by the daily cases curve, and this is I'm sure this is something that which you are very familiar, because I'm sure that physicians all over the world consult this website almost every day. we had a steady step increase in cases that reached the peak in the first 2 weeks of March. And then the curve started slowly to go down. And now we have the minimum number of cases. Unfortunately, we have paid a high price in terms of deaths, more than 30,000, and total confirmed case, more than 200,000 cases. The region I work now is Tuscany. I'm currently in Florence. We were the 5th region to be hit by the virus. But as you may note, this is today report. Now the number of cases is very low. We only had 12 cases today compared to yesterday. And this is nothing compared to more than 100 cases we used to have during the peak. There is still a large heterogeneity between different regions, and as you may know, in Lombardy, they still have in some areas hundreds of cases every day, where in Tuscany we have much less cases. From June 3rd, it will start the true phase 2 of post-pandemic peak, and we will be allowed to travel again from one region to another. But because of the differences between regions, probably we will not be allowed to travel to all regions, and there will be restrictions, and we will be permitted to travel only to the region that have the same contagious index as the region where we live. And these are few images of Florence, and for those of you who visited Florence before the COVID, I'm sure it is striking to see the city completely empty. I was actually allowed to travel because I was a doctor, and pulmonary physicians and nurses and healthcare workers were allowed to move, to go to work and then to go back home. And this is the train station and the metro during the peak of the pandemic, and there was really nobody, because everybody was at home with no possibility to get out except for getting cure or buy grocery stores and daily living necessity. This is today, and as you may note, after the phase 2 started, we now have more people around the city, but still we're keeping strict measure of distancing. So more than 2 meters are required between one person and the other. And we still are wearing masks and gloves all the time. Today was my first day at the beach, and this was the same for many Italian people. But again, beaches are not as they used to be, not so crowded, and people are really still quite scared. And many places in Italy are not fully back to normal. So the Ministry of Health has established 2 numbers of public utility, and recently has introduced a specific number for psychological support. We're living a period of post-traumatic stress, which is particularly evident in healthcare workers, but that is involving all populations. And so basically the numbers are going down, but we're not completely back to normal. And there is an effort to test people serology to detect antibodies that hopefully will be soon used to produce sera against the COVID-19 infection that might help to down-tune the viral load and to contain the damage that the virus can make.
Sara, sorry, we are not seeing your screen anymore now.
No, she's not showing it anymore.
Okay, yeah. Okay.
I was not going on with slides.
Okay, Mary is going to translate if you want, Mary.
Oh, okay.
Okay, so, perdón. Entonces, lo que ella habló fue sobre la situación actual de Italia y por lo que pasaron. Ella habla, como todos sabemos, que la situación comenzó en Italia, perdón, a fines de febrero, principios de marzo, hizo su pico de contagio en las primeras 2 semanas de marzo. Y luego de eso se empezó a ver una curva ya decreciente. Pero bueno, pagaron un alto precio durante ese pico y durante el manejo de la enfermedad, con más de 230.000 casos de enfermos y más de 30.000 muertes. Florencia, que es a donde ella vive ahora, tiene un gran control de la situación, con 12 casos más o menos por día, que eso es muchísimo menos que lo que tenía en tiempos de pico, que eran más de 100 casos por día. Y hay otros lugares, por la heterogeneidad que tiene Italia, en que siguen habiendo un alto índice de casos de contagio por día, por ejemplo en Lombardía. Ellos están ahora en fase 2. Fase 2 es una fase un poco más relajada de la cuarentena. La gente ha comenzado a circular por la ciudad, pero son todavía muy estrictos con la distancia social. No se permite estar a menos de 2 metros entre personas, y es obligatorio también el uso de barbijo, incluso de guantes. Tienen ahora, a partir del 3 de junio, un relajamiento adicional, ya que se va a permitir el viaje de personas entre regiones del país. Pero eso también va a estar restringido, o sea, no va a poder ser de cualquier región, sino más bien de regiones que tengan similar nivel de contagio. Ella lo que recalcaba era que la verdad que está habiendo bastante ayuda y consulta psicológica, que la población ha tenido un estrés postraumático muy fuerte, sobre todo en las personas asociadas al cuidado de la salud. Bueno, que en este momento lo que se está intentando hacer sí es testear a la población por la presencia de anticuerpos, y que incluso estos sueros de personas con anticuerpos negativos podrían eventualmente usarse para enfermos, digamos, para disminuir la carga viral y contener el daño en el sistema, sobre todo respiratorio. Sara, thank you very much for that description. It was really interesting. Before going on with the healthcare workers' conditions, I would like to ask you, do you believe that this downsloping in the cases is in some way artificial because of the social distance, or do you believe that you have had an important burden of people with the disease and now the virus cannot spread anymore? I know that there's a lot that we don't know, but in this way, I was asking if you somehow expect a second peak if you relax all the way. Can I translate and then you answer?
Yes.
No, lo que le estaba preguntando es si ella piensa, o a ella le parece, si este descenso en la curva es de alguna manera artificial, digamos, si no se generó exclusivamente por el distanciamiento social, o si le parece que, aunque todavía obviamente no se sabe, que puede ser ya por la importante proporción y cantidad de personas contagiadas y ya de alguna manera inmunes, que no permite la diseminación viral. Porque de no ser así esto, y de ser por un estricto distanciamiento social, obviamente al relajarse la situación del todo, podrían esperarse nuevos picos. So, sorry.
So this is a very important and interesting question. So my view is that most of this decrease has been related to social distancing. And of course, there is the fear of a second wave. However, there are some observations that the virus now may have lowered its virulence. This could be related to the fact that the most susceptible population has had the disease, either died or developed an immunity, and the rest of the population, which is probably younger, healthier, and with less comorbidity, could fight the virus a little bit better compared to the first wave. But social distancing is the key of this slowing down slope, for sure. And it's important to continue maintaining at least some of the rules that we have had these months.
Okay, thank you very much. So, lo que ella piensa es que el mayor descenso de esta curva fue gracias al distanciamiento social, pero por supuesto hay miedo a que ocurra una segunda ola de contagios. Sin embargo, ha habido observaciones, o se cree que el virus puede haber perdido algo de su virulencia, porque la mayoría de la población más susceptible ya ha sido, digamos, afectada o enferma y recuperada, o mismo los fallecidos, y que la población más joven tiene más herramientas para luchar contra esta enfermedad. Pero ella cree que el distanciamiento social es clave y que se debe mantener para que esto siga bajo control. Juani, do you want to go ahead, or do you want to make another question in this topic?
No, por mí sigamos adelante. Gracias, Mary. Sara, if you want, we can continue with the working condition of the healthcare workers. Please.
Okay, so the situation in Italy has been very heterogeneous. The first region that has been hit by a virus, that was Lombardy, paid a high price in terms of healthcare workers' exposure, and they also had higher numbers of positive healthcare workers and higher number of deaths. Other regions had more time to prepare, and I have to say that when the peak reached Tuscany, we had a couple of weeks to adjust and to reach all the PPI that the healthcare workers needed to work with COVID patients and to prevent the spread among healthcare workers. So the first thing that you have to deal with is the shortage of DPI, of personal protection instrument and tools. So if you want to translate this first part, and then I can keep on going with the rest.
Yes, Mary.
Okay. Bueno, dice que también en cuanto a a la exposición de los trabajadores de salud y las condiciones también ha sido muy heterogénea la afección. Las primeras regiones golpeadas por la infección, que es Lombardía, la verdad que los agarró un poco desprevenidos y tuvieron que pagar un alto precio en exposición y en contagio a trabajadores de salud, incluso en muertes. Hay otras regiones que tuvieron más tiempo para prepararse, y esto es que los trabajadores de salud adquieran más herramientas para protección, incluso que haya más trabajadores de salud preparados y educados para atender pacientes con COVID-19.
So, what we did in our unit, so I'm the head of the interventional pulmonology unit in Florence, and the first thing we did was we stratified COVID patients in cases that were suspected or confirmed, and we divided those and kept those separate from the patients that were with high confidence non-COVID patients. The high confidence non-COVID patient was defined as a patient that lacked any clinical or radiologic features of COVID and had at least one negative nasopharyngeal swabs done 48 hours before any procedure. So patients that were meeting these criteria, non-COVID patients, were treated with the DPI that you can see in this picture. So we were basically wearing 2 pairs of gloves, the mask that was an FFP3, actually we use FFP3 currently for any procedure due to the risk of tuberculosis. And then we wear masks and hats. And for suspected or proven COVID-19, meaning patients with a clinical or radiological features suggestive of COVID, even if nasopharyngeal swab was negative, we used the respirators. Powered air purifying respirators have the not only the potential to be highly protective for the healthcare operator, and here you can see that we have a sort of what we call in Italy a burqa that protects also the neck, but they are also very comfortable because they inflate fresh positive air, and you don't get foggy shades on your mask, and it is much more comfortable and easy to breathe with these air purifying respirators compared with the usual DPI. Of course, we use those in the COVID unit mostly, and mainly when we had to perform more than 3 or 4 exams, and these are easy to be wear for more than 3 or 4 hours, whereas without the respirators, it is sometimes difficult to wear the complete DPI for many hours because you sweat inside, they are very hot, and it is difficult to breathe and to work. So we can translate this, and then I will end.
Okay, this is fascinating, what you have over there. Lo que ella contaba es la estrategia que se usó para proteger a los trabajadores de salud. La verdad que parece muy inteligente. Lo que ella es la cabeza de la unidad de intervencionista, y lo que hicieron es estratificar a los pacientes en sospechosos o confirmados de COVID y aquellos que de ninguna manera parecían tener COVID, y a estos los definían como pacientes que no tenían clínica ni radiología de COVID y que tuvieran por lo menos una prueba de PCR negativa 48 horas antes del procedimiento. Y en estos casos los procedimientos los hacían con este sistema de protección, que era usar barbijos 3M, usaban obviamente 2 pares de guantes, camisolina, escofias, y este era el sistema, digamos, habitual de protección a los pacientes que no sospechaban que tuvieran la enfermedad COVID. En aquellos pacientes que sospechaban, que tenían COVID sospechado o probado, y esto es aunque tuvieran una prueba negativa, una PCR negativa, pero porque tenían síntomas o radiología compatible, usaban este sistema, que es un respirador purificador de aire, que es un sistema que les insufla aire a presión positiva, y que les permite trabajar, aparte en condiciones muy protegidas, porque incluso les protegía el cuello, de una manera muy cómoda, porque no les da ese sofocamiento, calor, e incluso la visión borrosa de los otros sistemas que no insuflan aire a presión positiva, y permitía incluso trabajar durante 3 o 4 horas seguidas de manera cómoda. Esto lo usaban en obviamente las salas que tenían pacientes con COVID. So that's it.
Okay. And of course, to perform bronchoscopy, we used some tips we adapted and adjusted to reduce aerosol production as much as possible. There are many strategies in the literature, and the easiest one is to put a suction catheter in the mouth of the patients and to use gauzes on the mouth of the patients in order to reduce the aerosol. Or you can even use a mask and do the bronchoscopy through the filter. We used disposable bronchoscopes, and this was for all COVID proven or suspected cases. And of course, as I've said at the beginning, I think there is a huge heterogeneity among different centers, and I'm not sure about the prevalence of healthcare workers that got infected in all Italian hospitals. In our hospital in Florence, we had less than 5% of positive healthcare workers, and the good thing has been that all healthcare workers has been tested. So it is an acceptable low rate. But all over Italy, we for sure had more than 3,500 cases, more than 165 deaths among physicians in Italy, and among healthcare workers, the infected are younger compared to the general population, and more frequently female compared to the general population.
Mary?
Okay, so, bueno, ella dice que las medidas que se tomaban para hacer broncoscopía, obviamente que eran distintas a fuera de la pandemia, que lo que usaban era un catéter de succión en el paciente, o incluso máscaras para prevenir la aerosolización y para disminuir el manejo, la cantidad de secreciones, y que utilizaban unos filtros y ponían el broncoscopio a través del filtro. Esto era para pacientes con COVID confirmado o sospechoso. Ella, cuando habla de la cantidad y de la carga de trabajadores de salud contagiados, infectados, no conoce la prevalencia total en Italia, porque de vuelta es un país muy heterogéneo, pero que en Florencia, que es donde ella trabaja y donde todos han sido testeados, así que sabe que, digamos, es un número fidedigno. El 5% de los trabajadores de salud fueron positivos. Se cree que hay más de 3.500 casos de COVID en trabajadores de salud en toda Italia y más de 165 muertes, y que la media de edad en esta población es menor a la de la población general, digamos, no trabajadores de salud, está en 49 años versus 63, y que hay más mujeres también que en la población general. Sara, if we are moving forward, in what patients did you practice bronchoscopy and why? In case of COVID and non-COVID, were you still doing procedures?
Okay, so the activity changed radically. So we stopped all procedures, and as the bronchoscopy societies recommended, we just kept on going with emergency urgent procedures or neoplastic patients, basically. So oncologic patients. For COVID patients, following EABIT recommendation, we tend to avoid bronchoscopy as much as possible. And in COVID patients, we performed bronchoscopy only for urgent procedures, so mainly patients that required disobstruction of the airways, because we know that those patients tend to develop very sticky secretion that tends to occlude the airway. And then I will tell you the rest, if you want to translate this part.
Okay, thank you. No, le pregunté antes de seguir adelante a quién y por qué hacían procedimientos invasivos durante la pandemia, tanto a pacientes COVID positivos como no positivos, y ella me dijo que claramente la actividad se paralizó, la actividad de endoscopía se paralizó, que se paró todos los procedimientos, pero que bueno, la sociedad de broncoscopía después permitió hacer para pacientes no COVID procedimientos de urgencia, y principalmente para pacientes con neoplasia. Y en cuanto a los pacientes que tenían COVID, trataron de evitar, bajo todo punto de vista, realizar procedimientos, solo también hacían procedimientos de urgencia, y estos eran más, sobre todo de desobstrucción, porque se sabe que los pacientes que tienen la enfermedad desarrollan secreciones muy viscosas que obstruyen la vía aérea, y entonces por eso había que intervenir. Thank you.
Thank you. And the most important, I think, role that we had during this pandemic as interventional bronchoscopy was to help all physicians that had to manage COVID patients to discriminate between positive and negative cases when the nasal swabs was negative, but there was a clinical and radiological suspicion. So those cases are very difficult to manage, because we know that the nasal swab has a very low sensitivity, which is around 60 and 70%. And when you have a clinical and radiological suspicion, you cannot really rely only on the nasal swabs. Here you see a slide, and I apologize, this is in Italian, because this is the original document of our hospital, of Florence Hospital, that and is one of the part of the diagnostic algorithm of COVID at our hospital. And as you may note, in the middle of the picture, you have BAL and the interventional pulmonologist evaluation. So in all patients in which there was a clinical and radiological suspicion, but 2 negative nasal swabs, the interventional pulmonologist was called to interpret the clinical and radiological findings. And radiological, I mean HRCT, so high resolution findings, to decide how high was the risk of COVID and to decide whether to perform or not BAL. And with this, we used basically BAL as gold standard for the diagnosis, because you know that from the literature, it is much more sensitive compared to nasal swabs, with a sensitivity that seems to be around 90% compared to 60%. So this was a huge undertaking for the group of interventional pulmonologists, because in fact the cases that were doubted to be COVID, but where nasal swabs negative were more than 150 in our hospital. So we evaluated a significant number of cases with BAL. And finally, we found that only 10% of those, in fact, were BAL positive, but this was hugely a huge help for physicians to decide where to allocate patients, whether in COVID or non-COVID areas, and how to treat patients. So I think this was a very important piece of information that the interventional pulmonologists gave during this pandemic.
Okay, so before translating, can I ask an additional question, and then I translate all together? So the patients that were negative, the 90% of patients that were negative in the BAL were considered negative for COVID and were non-isolated and
yes,
non-treated as such?
Yes, exactly. But there was a good concordance between the negativity of the BAL and the pretest probability. So we're now looking with the study at the concordance between the confidence in the clinical radiological diagnosis of COVID and the BAL results. So when the clinician and the radiologists had a higher suspicion of COVID, that was the population in which the BAL actually was found positive.
So would you suggest a BAL as a procedure to either confirm or rule out the COVID, or just where you work, because you have all these tools that you mentioned on how to proceed?
Exactly. So the first point is you can build an algorithm like this only if you have the procedure that can, the protective equipment that can allow your personnel to work safely. Otherwise, you cannot perform the procedures. This is a very important point. And if you don't have the personal protection tools, then you have to rely on clinical data and on HRCT, and you cannot expose your bronchoscopist and your nurses to the risk of BAL and risky and aerosol producing procedure. But if you have the respirator and if you have the right environment, I know that many endoscopies in Italy were able to implement a true endoscopic COVID endoscopy room with negative pressure, clean and dirty areas for the personnel. So if you have the right environment and the protective equipment, well, in that case, I think that BAL can really add important information. Also for differential diagnosis, so to ascertain an alternative diagnosis in non-COVID cases.
Okay. Okay, thank you very much. Bueno, ella, la doctora lo que nos estaba comentando era sobre el rol que tuvieron los broncoscopistas durante la pandemia, sobre todo para discriminar los pacientes positivos y negativos con COVID, y esto cómo estaba puesto en el algoritmo que ellos hicieron en su hospital. Todos los pacientes que tuvieran clínica y radiología sospechosa de COVID, pero que tuvieran un hisopado nasal negativo, 2 en realidad hisopados nasales negativos, se sabe que la sensibilidad del hisopado nasal es del 60-70%, pero que tuvieran alto riesgo de tener la enfermedad, ellos, por protocolo y por algoritmo de donde ellos trabajan, repito, realizaban un lavado bronquialveolar, que es el gol estándar para el diagnóstico, ya que tiene una sensibilidad tan alta como el 93% contra el 63% del hisopado. Y ellos, de los 150 pacientes que encontraron, que realizaron el VAL, encontraron un 10% de pacientes COVID positivos. Entonces, la realidad es que todos los otros los consideraron negativos y no los aislaron y los trataron como tal, pero esos pacientes tenían un pretest de enfermedad bastante bajo también. La pregunta que le hice a continuación es si pensábamos que entonces el VAL, siendo el gol estándar, tenía que ser implementado en todos estos casos dudosos o con hisopado negativo, y esto es muy importante, debe ser solamente realizado en casos donde exista un equipo y un ambiente protector al médico intervencionista, porque si no lo pone en riesgo, y de no ser así, lo que hay que confiar es en esto que hablábamos del pretest clínico y radiológico, y los pacientes que tengan, digamos, un alto pretest ser tratados y manejados como tal. Pero lugares donde se tengan los medios adecuados, que fue en varios lugares de Italia, no solo en su hospital, la verdad que fue una herramienta muy útil de implementar.
Mary,
Yeah.
muy bueno, Mary, muy bueno. No, quería avanzar, a ver si Adrián le puede hacer una pregunta sobre diagnóstico por imágenes, ¿te parece?
Sí, perfecto.
Sara, if you don't mind, Dr. Adrian Gasser, our radiologist, is going to ask you about images. Adrian?
Hi, Sara. First, I want to ask you, in this clinical radiological evaluation prior a bronchoscopy, you use CT as screening.
We didn't use CT as screening, but we performed, for screening, when the patient arrives to the emergency room.
No, I'm speaking for this prior bronchoscopy, not like in the diagnosis for COVID.
Okay, yes. So all patients that had 2 negative nasal swabs underwent HRCT, yes.
Okay, thank you.
And all were evaluated. It was a multidisciplinary evaluation. So I was evaluating the clinical part, and the chest radiologist was evaluating the HRCT, and we were defining the class of the risk. So it was a multidisciplinary teamwork.
Fine, thank you. And do you have any protocols for chest imaging in diagnosing COVID in suspicion patients in your institution? You are using X-rays, CT, ultrasound?
Yeah, so they're using both chest X-ray and ultrasounds in the emergency room, but ultrasounds are more useful for complications and for the follow-up of the patients.
Okay.
X-ray was easier to perform compared to CT scan at our hospital, because it's a big hospital with different buildings, and it was not easy to perform HRCT in all patients. So we decided not to use CT scan as a screening tool, and basically they've used chest X-ray. And patients that had mild symptoms and negative chest X-ray were sent home. So the screening tool was chest X-ray.
Okay.
Excellent. Mary?
Bueno, Adrián le preguntó si en este algoritmo ellos lo que consideraban clínica y radiológicamente sospechoso, lo de radiológico era una tomografía, y ella confirmó que sí, que así era, pero en cuanto a lo que era protocolo de screening en emergencia, se usaba principalmente radiografía de tórax, que pacientes con síntomas leves y radiografía negativa eran mandados a la casa, y que la ecografía pulmonar se utilizaba más bien para la pesquisa de complicaciones y para el seguimiento de los pacientes. Que la tomografía no se hacía en todos los pacientes, que no era muy fácil de implementar, por lo menos en el hospital donde ella trabaja.
Ok. Mary,
Yep.
no sé si Silvia quiere hacer alguna pregunta o comentario. Después le voy a decir a Betty también. Silvia?
Well, probably if I have the dates right, you said that the peak of the cases was the middle of March. And in fact, you opened the lockdown only at the middle of May. So you waited as a country with regional differences, almost 2 months to open the lockdown, not completely, after the peak of the cases. Am I right? Yeah, yes. We waited almost 2 months. Yeah, that's 1 month and a half. And we waited until the contagion index, so the R0 was below 0.2. And when in the most of the region we reached that, then they decide to reduce the restriction measures. Unfortunately, the pandemic curve has a steady increase, but a much slower decrease. And so I think the most of the country will be forced to wait at least 4 to 6 weeks after the peak before reopening. Yeah, this is extremely important for us because we are going to have a very atypical curve just because we started the lockdown very early. So it's very difficult to compare. We are expecting the peak of cases probably in 2 or 3 weeks, and we have already been in isolation for almost 2 months or a bit more. So of course, people are very anxious about, opening, mainly going back to work. But that was, I thought it was important to remark that unfortunately, only the social isolation or distancing is the only preventive measure we have. Yes, I wanted to remark that side. Yes.
Okay, do you have any further comment, or I just translate what?
No, you can translate. Thank you.
Okay, so Silvia estaba haciendo una observación muy importante, que era que Italia tuvo el pico de casos a mediados de marzo, y un poquito menos de 2 meses después, ahí comenzaron a liberar un poquito el distanciamiento y la cuarentena. Y Sara confirma esos números, dice que sí fue más o menos 6 semanas después, cuando ellos lo que miden es un índice de contagio, el R0, que fuera menor a 0.2, y recién ahí, cuando llegaban a ese número, se permitía un poco la apertura en los distintos lugares. Ella lo que cree es que la tasa y la curva de subida tan alta no correlaciona con cómo baja, que en general la declinación es bastante más lenta, y que en general lo que le parece que sucede es que sí, que en los países se va a tener que esperar de 4 a 6 semanas después del pico para reabrir. Y nada, y Silvia recalcaba que nuestro país se va a comportar de manera más atípica por la cuarentena preventiva y prolongada que ya hemos tenido previo al pico, y la ansiedad social que se genera y económica por este aislamiento tan prolongado. Ok.
Adrián.
Yes, Sarah, I have another question about imaging. Do you use a structured
Report.
reports for the cities?
No, we didn't. I think it's a great idea to do it if you have the chance. I mean, we were a little bit overwhelmed by the peak.
Yeah.
Because even the multidisciplinary discussion was a challenge during the peak of the pandemic. But if you have time to structure your report, I think this is a very good idea. Probably the best thing would be a structured multidisciplinary report where you have a few clinical notes and then few radiologic notes and then the conclusion. COVID, non-COVID, and what is your confidence level on that?
Okay, thank you.
We are reviewing the data that we have collected, and we want to see in a sort of experimental setting. We want to expose a clinician and radiologist to the data and see if we can structure a way to make a diagnosis, how to make a diagnosis, and how to define high confidence and low confidence cases. But we haven't done it really prospectively, so it would be great if you can do it in your countries. Yes.
Okay, so Adrián le preguntaba si en cuanto a tomografías ellos tenían reportes estructurados que han sido descritos para COVID como típicos, indeterminados o atípicos, y se basaban en eso, y ella dice que no, que lamentablemente se vieron sobrepasados por la situación y la cantidad de casos, así que no lo hicieron, pero que sería algo muy inteligente de hacer, de poner si una tomografía parece COVID o no COVID, y el nivel de confianza de ese diagnóstico, y que ellos ahora están revisando toda la data que tienen y tratando obviamente de sacar mayores conclusiones. Juan, ¿y puedo hacerle una pregunta o tenemos poco tiempo, no?
Sí, sí.
No, so we have, I think, 10 minutes left, and you are in a very different situation as we are, and as Cynthia said, our lockdown has been too long for now. So what do you believe it's the way out of this? What is your expectancy about how many months are going to pass until we can get to normal life, or traveling through different countries? Or do you think, or have you experienced any trial about treatment? I don't know, have you any ideas about the way out of this pandemic?
Honestly, I'm not.
Sorry, can I translate first?
Yes, sorry.
No, le preguntaba, y nos quedan 10 minutos, y que bueno, que nuestra sociedad se está impacientando y ellos están más de salida, o por lo menos en otra situación totalmente distinta a la nuestra, y que mi pregunta era si ella veía algún tipo de salida o de cuánto iba a durar esto, si ella tenía experiencia en algún estudio que se ha llevado a cabo, que se estuviera llevando a cabo en cuanto a los tratamientos, y bueno, cuál era su visión de futuro, por más de que fuera una visión nada más.
So I think it's difficult to have a clear vision of the future right now. What I can see for the next month is that we will not stay locked at home. We will restart working, and we will restart with our social activity, at least most of them, but in a completely different way compared to the pre-COVID era, because we will still maintain distances, we will still wear our masks all the time, so it will not be the same as it was. It will end probably when we will have a vaccine, and this, I think, will be before finding a cure, because we know that the damage of COVID is basically an acute and diffuse alveolar damage combined with extensive microthrombosis and thrombosis of the large vessels. So it's a very complex pathogenetic pathway that is activated through the lungs and to the vessels. And I think it's going to be pretty challenging to find a cure for this. But we will see the end when we will have the vaccine. And I really don't know when this will be. For pulmonology, I mean, not only our life will be different, but I think that for pulmonology, many things will change, because we can expect a significant number of post-COVID cases of interstitial lung diseases. And I still don't know the significance, the meaning that they will have, whether they will be fibrotic, whether they will be progressive or not, whether they will need treatment or not. But for sure, this will be a big challenge for pulmonology. So we will need to organize a way to follow this patient, to collect the data, and to find all the resources and the fundings that we will need to look at this post-COVID ILD or fibrosis, whatever it will be in the next future.
Okay. Yeah, thank you very much. Bueno, ella lo que dice que es muy difícil tener una visión clara del futuro, que claramente en Italia van a empezar a hacer una vida un poco más normal, que la gente va a empezar a trabajar, que la gente va a empezar a tener más vida social, pero de una manera distinta a la prepandemia. Digamos que ahora ya el barbijo o el tapabocas es algo impuesto, lo mismo el distanciamiento social, y que ella, en su opinión, cree que esto va a terminar con la aparición de la vacuna, que no sabe cuándo puede ser eso, pero que le parece más factible que sea con la aparición de la vacuna que con un tratamiento efectivo, porque la fisiopatología del daño pulmonar es muy compleja. Hay por un lado un daño alveolar difuso y por otro lado una injuria microvascular, así que es muy desafiante encontrar un tratamiento que pueda abarcar toda esa patología. Y por otro lado, y es un poco lo que queríamos abarcar para el final, era esto de lo que se especula, que puede haber aparición de enfermedad intersticial post-infección por COVID, que eso no se sabe en realidad el significado clínico, pero se cree que sí, que es una posibilidad, pero no se sabe si esa enfermedad intersticial va a ser fibrosante, va a ser progresiva, incluso si va a requerir algún tratamiento. Así que toda la sociedad científica va a tener que organizarse e invertir muchos recursos en trabajar en esto y en averiguar las implicancias.
Gracias, Mary. Le voy a pasar la palabra a Betty para que haga una reflexión o pregunta final. Betty, querida.
No en italiano, por favor. No en italiano.
En español. Si Sara no entiende, le traduce. Sara, antes que nada, agradecer tu generosidad por compartir con nosotros este momento. Allá en Italia es tarde ya, así que grazie per la tua generosità. Una pregunta, Mary, que vos le podés hacer en inglés, porque creo que nos han seguido muchos pacientes con fibrosis pulmonar, y en referencia a lo que Silvia nos decía del tiempo ya prolongado de una cuarentena que ha sido muy preventiva. Después veremos si a favor, si pensamos hasta este momento que sí, pero son pacientes que están con miedo y con angustia de que esto se siga prolongando, más aún nuestros pacientes específicamente que padecen la fibrosis. Entonces, teniendo ella ya la experiencia con su grupo de pacientes, ¿qué le diría a los pacientes que nos están siguiendo? ¿Capito?
A message for our patients. We have some patients now join us by YouTube. So Betty is asking for some words and a message for our patients with ILD and with pulmonary fibrosis.
So I have to say that our patients were probably very well. I mean, they knew exactly how to behave, probably because they already knew how to protect themselves for infections, and they applied this knowledge to the COVID. And thanks to this, I mean, and to the fact that they stayed at home and they took all the precaution they had to, we did not observe COVID cases in our ILD cases, nor in Florence, neither in Forlì. I know only of one case in Rome that unfortunately got COVID in the hospital, and he was hospitalized for other reasons. So it is very rare for ILD patient to get infected. And I think this is because they know how to protect themselves. Of course, they must restart to have a life, but again, social distancing, hand hygiene, and masks needs to be aware all the time. I hope that they will be one of the first category of people to get the vaccine when it will be available. And right now, they probably need our support and also psychological support. And we should organize some web-based or telemedicine to help them to stay at home as much as possible.
Okay. Thank you.
Thank you very much. So this is a very important message, just to round up. Ella lo que piensa es que la realidad es que los pacientes que tienen enfermedad intersticial y fibrosis pulmonar ya han aplicado en su vida el conocimiento que tienen para prevenir infecciones y que lo están aplicando en este momento, y que por eso, gracias a Dios, han sido, la verdad que muy raros. Creo que conoce uno solo en Roma de pacientes con enfermedad intersticial que hayan tenido COVID, pero esto es gracias a su concientización y a que han tenido cuidado y se han quedado en sus casas. La realidad es que ella cree que obviamente tienen que empezar a tener una vida, pero que es importante recalcar que sea con distanciamiento social, y que seguramente cuando salga la vacuna sea de las primeras a las que se le pueda aplicar, y que tienen y requieren de nuestro soporte y de nuestra ayuda, y obviamente un soporte psicológico, y que nos pongamos a disposición de ellos con herramientas de telemedicina y todo lo que podamos para que ellos se guarden seguros.
Bueno, muchas gracias, Mary. Nos vamos a despedir. No sé si hay algo más. ¿Alguna pregunta?
Me parece que ya estamos, pobre Sara. Dejamos.
Sara, we'll let you go to sleep. Thank you very much. Do you want to say any more? Something else?
No, I just want to say thank you to all of you. You were wonderful. This was really interesting, and thanks to Silvia, to Juan, to all the wonderful people that invited me and that organized this. Really, thank you very much to all of you, and to Mary for the translation, to the radiologists and to the doctors for the ILD doctor for the questions. So thanks a lot. Thank you.
Thank you very much. Hope to see you soon, virtually and face to face. Yes, in person.
Yeah.
Gracias.
Thank you very much, Sara.
Thank you so much.
Thank you very much.
Thank you.
Very nice to see you.
Bye.
Thank you. Bye-bye.
Bye-bye. Thank you.
Bye.
Bye-bye. Thank you very, very much, Sara. Rest.
¡Qué lindo!